Now we're going to talk about cluster headaches. That's
Right.
one of your specialties too.
Absolutely. It is, some people call it cluster migraine because it is, but usually there's not a constriction phase associated with that. It's just dilatation, and it's distributed in the face and the eye and behind the eye. And usually you get associated tearing, your eyes water, and you get a running nose. So that's one of the things. You get a flush in your face, and those kind of headaches are precipitated very often by alcohol, and they're more in men than they are in women. Whereas the classical migraine is probably more in women than in men. And
What's the
cluster
treatment?
headaches
Clusters.
occur in clusters of 6 to 8 weeks at a time, and then they're gone for a good period, maybe 3 months to 6 months, and then they come back.
Wow.
And the treatment of cluster headaches, of course, the acute headache now is Imitrex and Maxalt, that group of drugs that just came out about 25 years ago. I gave a paper at the American Association of Neurological and Neurosurgical and Orthopedic doctors, physicians in Las Vegas about the use of Imitrex in cluster. I was one of the first to use it in it because we were using it in migraine before we started using it with cluster headaches. But the big thing is to avoid alcohol and make sure you get adequate rest. We also use corticosteroids after that first one, and then to prevent them from coming back, we use corticosteroids for 4 to 6 weeks to knock them out. A fairly large doses, and then gradually reducing it.
Oh, okay.
And that's one of the. But we don't use corticosteroids for migraine as a rule.
You don't?
No.
What do
it's
you
not
use
effective.
classically for
Okay,
migraines?
for acute migraines, same Imitrex, Maxalt. We use you take 20. If you're going to take it orally on the Imitrex, you take 25 to 50 all the way up to 100, and you may repeat that once in 24 hours. There's an Imitrex spray.
Oh.
And then we have another spray called Stadol spray that if that doesn't work, we can spray that in the nose, and that will get rid of the acute headache. If you go to the emergency room, you can get a shot of Benadryl.
Oh, there you
And
go.
a Dr. Godoni and myself started using that back in the early 80s, 50 to 100 milligrams IV slowly.
Wow.
You can use it IM, but it works better IV. And Benadryl is just a very
Explain to them what
benign
IM.
drug. Intramuscularly would
Okay.
be IM. But Benadryl is very good at attenuating a migraine without using narcotics. We try to steer away from narcotics because people get addicted to the narcotics. They'll come in. Years ago, 40, 50 years ago, we were using morphine and Demerol pretty regularly to treat acute migraines, but we know better than that now, and we try to get away from that. And Benadryl is one of the best substitutes. Of course, it also helps the nausea and vomiting, and so does Phenergan. Now, Phenergan sometimes can relieve the headache and the nausea and vomiting together, but Benadryl is far better for relieving the headache. That's the acute phase we're talking about,
Okay.
without using narcotics. Also, Imitrex you can give intramuscularly.
Yes.
So you don't have to rely on oral medication or the spray for that. Now, to prevent migraines, we already talked about the foods, and Dr. Brainard has a book called Control of Migraine that he has listed all those in there, and you can get that on the internet, or there's still copies around in the bookstores, I'm quite sure. So you can order it on Amazon. But he lists all the foods, and then he lists some of the prophylactic treatment that we use. Number one is the beta blockers. And that's something like way back Inderal. Now we have a longer acting beta blocker called atenolol, and you can use that starting out with 12.5 milligrams once a day. and gradually working up to 50 and sometimes 100. And I like that. We also use we use the different beta blockers besides that. And then there's a group of anticonvulsants. The one that I like, these are drugs that are used for epilepsy. That's why we call them anticonvulsants. But they also work to prevent migraine. And I've used Dilantin for 50 years. And because it was around long before some of these others. But a lot of people are using Topamax. They're using Depakote and Depakote. But these are all anticonvulsants that prevent migraine. Another drug that is very good in prevention is Elavil, or amitriptyline is a generic name for that. You can take that at night, and then of course it prevents the migraine. And sometimes when the beta blockers like atenolol and Inderal don't completely suppress the migraine, we add the Elavil at night, or one of the other tricyclic antidepressants at night. And now the SSRIs like Prozac and the SNRIs like Duloxetine, Cymbalta, they can help, but they're not quite as successful as the tricyclics in preventing the headaches.
Interesting.
And now we need to address Botox. The problem with Botox, you're going to have to get shots in trigger points all over your head.
Yes.
And it's very effective.
Okay.
And there's not too many side effects unless you are very sensitive to the toxin. But the idea is that you have to go get shots, and a lot of people don't like shots. And there's a new drug that just came out that you can take once a month, and I'm not real familiar with it, so I'm not going to go into it. But I see it advertised on TV now. So we'll have to look into it and see whether it really works. I haven't had a chance to test it or read much on the literature about it, so I won't go into that too much. Another possibility is Periactin, and that works very good in children. We used to have a very good drug for adults and children called Sansert, but it was taken off the market because it caused retroperitoneal fibrosis, and it's too bad because it was one of the best. I used it on a little girl who was an Olympic star, and she did so well on it, and it's just a shame that there's not, but that was back when it was still acceptable.
Speaking of which, when you're talking about the, what was it you just now, you went into? I'm off to cut.
Periactin, that's an antihistamine, 4 milligrams twice a day. You take up to 8 milligrams twice a day.
Periactin,
And
but
that's
then
an antihistamine.
what was the drug that you used for the Olympic?
Oh, that was Sansert.
Sansert.
Yeah, that was Sansert. But they took it off the market because
I know what I wanted to also ask you about, is this is widespread with people today. Everybody's giving this diagnosis. It's called fibromyalgia.
Oh, yeah, okay. Fibromyalgia has no laboratory or objective physical findings or neurological findings, and that's why half the medical profession doesn't believe it really exists.
Well, then why are they giving everybody that diagnosis? I mean,
because
so many
it's
people.
a wastebasket term. They can't come up with anything else. But there is some literature where there's trigger points in certain areas of the body. For instance, on the costochondral junctions in the occipital area. I'm sorry, I'm stumbling on my words here. And so there's 18 trigger points that seem to be consistent. So that's,
amazing.
But that's not proven. It's mentioned in Harrison's Principles of Medicine, but I think there's a lot of controversy about fibromyalgia, and a low pain threshold probably explains it better than anything else, because most of these people have depression and associated psychological symptoms. So we do think a low pain threshold explains it.
Now I'm going to come right back and we're going to talk about diet
Okay.
and exercise.